I think you all recognize, so I would normally apologize, but I think no apologies are necessary for this particular interruption, right? And it is, we all know how busy the secretary's schedule is, so really, I have to say personally, and I know Jim feels the same way, it's really very good of her to take the time, and I have no doubt of her sincerity and how important it is for us to continue the deliberations from where your board left off. And with that preface, I'm going to turn, Jim has a question. So we're back in business as far as.
And we probably only have a few more minutes to grill you before the roundtable, and I hope you'll be staying for the roundtable. But I just wanted to clarify, is it indeed the case that the board assumed that the risk of an event, the board did not, the board passed no judgment on the risk of an event, just assumed that the risk of the event is non-zero, and then answered made their recommendations subject to that. And I guess for our commission, is that a same place we are comfortable starting from?
Your assumption's correct. We did two things up front. Did not debate the threat. We accepted the threat, laid down by the people that are paid well beyond my level to analyze and prioritize our threats. The risk of that threat, I believe if they do have any sort of a number, it is greater than zero, or it's not a threat. So, but the absolute risk was not debated because we assumed that that went along with the threat. But in that same context, we all recognize that it's a risk to the nation, but when you boil the nation down to an individual, that risk does change. And so the probability of any one of our children being involved is much less than the national risk, but we don't know what those numbers are. But yes, we did discuss that. But putting that aside, though, that if there is a risk and it happens to an area of our country and any children or adults are involved, that's 100% for those people. So we made our recommendation on the basis of that.
And I think I just think that's critical for us to establish and imagine how we think. Obviously, if the risk of, I think it is obvious, if the risk of event is greater than the risk of an untested deployment or an untested response, and the risk of an untested response, in turn, is greater than the risk of testing, that gives us a pattern.
Let me just read something from the public, members of the public. Actually, it's, do I have Dr. Fagbayi? Yes. Yes. Did I pronounce your name correct? Okay. Shall I read? Let me read what, it's really a response in some sense to my question in numbers. The medical director of Children's National Medical Center. So antibiotic side effects in children include nausea, vomiting, diarrhea, fungal infections, Stevens-Johnson syndrome. Challenges to children with special needs, G-tube, kids with allergies to medications, resistance risk, all can preclude use of antibiotics. That's an important extension. Did you want to add anything to that? Briefly.
With regard to
Here. Yeah.
Oh, sorry. Thank you. Not that I need a mic, but I think we were talking about the risk of antibiotics.
Yes.
With this whole 60-day regimen. It's not something to kind of wink at, and as my colleague John Parker had mentioned, that this is a chore, but I think under that word was the details of what you asked.
Right, okay.
With regards to allergic reaction. Stevens-Johnson syndrome is not something to play with. It's also life-threatening also. So there are other things that can preclude the use of antibiotics in compliance for 60 days.
That's what I was
that was-
asking. I just wanted, the notion of it being a chore made it sound like it was simply a question of people's will to continue taking it, but it's significantly more than that.
You probably need to wrap this here.
I'm going to, Alex, did you want to say something
Just-
briefly, and then I'm going to wrap?
Right, very, very brief. First, thank you, General, for your service to the country, too. I don't think we say that enough of our armed forces people. I, too, am a recipient of the vaccine, so, you know, maybe we can commiserate over our arm soreness later. But one thing that I did want to ask you, though, is you said there was one dissenter, and I was wondering what the issues were with the dissenter.
Would you, I didn't.
Sorry,
Yeah,
you said when you took the vote, they're usually unanimous. You did have one dissent.
What were the issues?
What were the issues that the person who was dissenting?
I'm really not in a position to speak for the individual, and it's not in the manner of the board to interrogate someone who has a vote that is not in concert with the rest, and we don't have an ability for a minority to form an opinion. But I do know the individual pretty well, and I think in all honesty, this member looked at the risk of the event, looked at the absolute need of having this safety data, and the idea of involving children in this particular research, and that member just couldn't put that together for a yay vote on the recommendation. The other thing that brings up is, you know, when people talk about threat, you and I who are in the business, and Dr. Michael, who are constantly in the business or constantly in the weapons of mass destruction defense business, it's a big deal, and all of these things become threats. But if we live in Kansas, a tornado or a drought may surely outwalk any threat that we talk about in these erudite kind of situations. But yeah, yes, one of the wonderful things about the board is that there is no coercion. We don't waterboard, and we don't ask people why they, unless they want to express it, why they feel a certain way. And so I was very comfortable with the individual saying no to the recommendation.
And don't misinterpret my question. I was really wanted to make sure that there wasn't something that we hadn't thought about before.
Your presentation and your response to questions has been marvelous, and we really do thank you and realize that we have a tall order coming and deliberating on the basis of what your board did. So on behalf of everybody, thank you very, very much.
Thank you, Dr. Green.
And will Professor Hodge and Drs. Taylor and Kaplowitz please come forward? As they're grabbing their seats, this next section is one where we'll discuss special ethical considerations that arise in medical countermeasure research and use. Speaking to us first is Dr. Lisa Kaplowitz. Welcome. She is the Deputy Assistant Secretary for Policy in the Office of the Assistant Secretary for Preparedness and Response at the Department of Health and Human Services. In this position, Dr. Kaplowitz is responsible for directing and coordinating policy and strategic planning for all components of that office. Previously, she was the Deputy Commissioner for Emergency Preparedness and Response in the Virginia Department of Health and served as Director of the Health Department for the City of Alexandria in Northern Virginia. In addition to public health and emergency preparedness, she has a strong interest in health policy, healthcare financing, and an improved access to healthcare. We're pleased to have you join us.
Thank you very much. Today, I will be describing the requirement setting and risk evaluation for an anthrax bioterrorism event specifically, but in the broader context of how we plan for a range of high consequence but low frequency public health emergencies. My office within ASPR is responsible for coordinating activities of the Public Health Emergency Medical Countermeasures Enterprise. We call it the FEMC. It's a federal multi-agency, multi-department enterprise responsible for setting policy and determining requirements for medical countermeasures for treatment and prophylaxis of illness, resulting from a broad range of emergency events impacting public health. The FEMC addresses the continuum of medical countermeasures development and use, from setting requirements to basic research, advanced research and development, purchase, stockpiling, delivery, distribution, and dispensing of medications and other treatment or prevention modalities to populations at risk at the time they're needed. And we describe this as end-to-end medical countermeasure enterprise. Chemical, biological, radiological, nuclear, medical countermeasure requirements for civilian populations are determined through an interagency decision-making process within the FEMC, framed in concert with and as a result of risk and threat assessments from the Department of Homeland Security. The process has multiple components with determination of threat and likely event scenarios, including the determination of requirements for specific treatment and prevention measures. The end product yields answers on the type and approximate quantity of medical countermeasures needed, as well as issues related to special or at-risk populations within the general population needs. And authorities come from the Project BioShield Act of 2004, the Homeland Security Secretary, in consultation with the HHS Secretary and heads of other agencies, shall assess current and emerging threats of chemical, biological, radiological, and nuclear agents, and determine which of such agents presents a material threat against the United States government and United States population. So the Secretary of Homeland Security establishes a material threat to national security exists by making a material threat determination, or MTD, that is based on a material threat assessment that takes intelligence reporting, assessments of technical plausibility, and exposure modeling for various release scenarios into account, and establishes the high consequence scenario that could result from a deliberate attack. The risk of an event incorporates both threat and probability of an event, as you've discussed already, as well as the consequences for a population. There are inherent uncertainties in determining the risk, and we really can't give a number to any specific risk of a bioterrorist event based on available intelligence and unknown probability of any single event or scenario. On a relative likelihood scaling, certain threats, such as anthrax, stand out in our planning and have material threat determinations. The FEMC addresses a broad range of possible bioterror agents, as well as chemical and radiologic events and outbreaks such as pandemic influenza. But as you've talked about already, the term risk means many different things outside of the traditional Homeland Security environment, and I wanted to bring up several different kinds of risks when considering ethical considerations. You've already heard about and discussed considerations related to clinical testing of countermeasures that may never be needed, since it is impossible to know with certainty the likelihood of a specific event actually occurring. There's risk related to delay in recognizing exposure and delay in instituting treatment, which can certainly result in illness and death. And you've already talked about the risk of lack of appreciation of altered risk-benefit ratio once an event has occurred. The risk-benefit calculus of any prophylaxis or treatment is very different during an actual event when the likelihood of illness or death is high than during the planning period when the risk is perceived as very low and largely theoretical. As a former state and local public health official, I can tell you firsthand that even under the best of circumstances, providing treatment en masse with licensed products, whether medications or vaccines, is difficult and challenging. To the extent that the process is slowed or complicated by other factors, the risk of illness will increase. A more complicated process not only reduces the number of people who can receive countermeasures quickly, but creates additional fear and confusion in an environment where there may already be illness and death. If children and adults are treated differently during an emergency, this will need to be addressed with optimal messaging to avoid the risk that the public will believe that we care less about children after an event. And I believe, as Dr. Parker mentioned, the importance for government to maintain the public's confidence cannot be overstated. We are seeking to avoid delays in treatment and complicated messaging, which in and of themselves pose real risks to the confidence of the public. The safety and protection of children is paramount in any discussion of medical countermeasures, and you've already heard that from Secretary Sebelius. We want to make sure that all issues are thoroughly addressed and all ethical considerations related to having adequate and available safety and immunogenicity data on our medical countermeasures to protect them before and during and after an event, and to be sure all these issues have been adequately addressed when there was time to plan ahead. I hope that I have conveyed to the Commission that the risks involved go well beyond the likelihood of an event, which is really unmeasurable, and that you will consider all the broad range of risks in your deliberations. Thank you.
Thank you. Next is Dr. Holly Taylor, currently Associate Professor in the Department of Health Policy and Management at the Johns Hopkins University Bloomberg School of Public Health, and a core faculty member of the Johns Hopkins Berman Institute for Bioethics. Before pursuing her doctoral degree, Dr. Taylor was a presidential management intern in the Department of Health and Human Services and spent 2 years as a special assistant to the director of the National Institute of Allergy and Infectious Diseases. She has served on institutional review boards of Johns Hopkins Bloomberg School of Public Health and the Johns Hopkins Medical Institutions, as well as IRBs in private, nonprofit, and federal settings. Her primary interests are research ethics, local implementation of federal policy relevant to human subjects research, civil biodefense, HIV/AIDS policy, and qualitative research methods. Welcome to you.
Thank you for that introduction, and thank you for inviting me to present today. So I want to thank in advance all of the folks that came before me, because many of the issues have been discussed, and it means I can sort of cut to what I think is the chase of my presentation. So I wanted to start, though, with, given my own background and given the way I approach research ethics questions, Dr. Gutman mentioned this article by Emmanuel that is now on your website. It's a way to sort of articulate the things that I would review in my own assessment if someone came to me with this question. I've highlighted the 3 things that I think are most important as we move forward, not to diminish the others, but I think those 3 are the ones that I'd like to focus on. And the way I would sort of articulate this is to first start with the question, or the first decision point is, does the project have social value? And I think that's a really important one for you all to decide, and I think whether you can come to consensus on that is an important one. If the answer to that is no, the study can't go forward. In thinking about social value, a component of that is under what circumstances would testing a countermeasure in a pediatric setting be ethically acceptable? A number of these have come up already. Can we do it when there's a potential threat, reliable information about that threat, exposure in a nearby community, during an event, or after an event? And I think there's different ways to articulate the pros and cons of doing each of those. The next question is the study design valid? And we've talked a little about that, and I think what we've been speaking about most is the phase 1 trial or a variation on that to determine safety. But the related question, or the first question, is there uncertainty about the potential benefit of the proposed intervention? And I think we've already sort of talked about, can we extrapolate from the adult population and make a decision about that benefit, or what value will such a trial add to our assessment of that benefit? The next question would be, do the risks to which the subjects will be exposed constitute a more than minor increase over minimal? We've talked quite a bit about this, and I'd just like to highlight the last note, and which I think is sort of the most problematic, is what's the risk of not conducting the study? And I think that in particular is the component of the analysis that those of us who think about research ethics proper, that is, whether to test a therapeutic in a child, we often don't necessarily think of this in the larger social context, or don't need to. We then have to think about the risks and benefits and whether those are balanced, and only if they are can we go forward. And what I'd like to do is just sort of graphically display this. This is how we generally think about balancing those risks and benefits. There are risk to identifiable children, future benefit to not identifiable children, though those who are sort of in close proximity to us in the life course. We also think about, in conducting pediatric research, there's sometimes a potential benefit to pediatric subjects. I don't believe there's a potential direct benefit to pediatric subjects in this context, and so we're really talking about the balancing the potential risks on one side and the future benefit. And as I said before, I think the real issue to consider is the potential risk to future children if we don't do the trial. And this doesn't quite show up as well as I thought it would on my slide, but I'm sort of putting this in the context of national security. And just again, if you start to think about where to place those, this potential risk to future children doesn't actually fit, I don't think, in our current ethical analysis of the way in which we think about this. I want to just split through some of these and get to where I think the sort of most important issues are in terms of the consequences of non-action. We've talked about what we would do if there is an intentional release, and that there would be some post-exposure prophylaxis, the known risks that were just presented by our colleague from the Children's Hospital, and then the post-exposure vaccination under an IND and I guess under an EUA. And then just to add a little data, we've talked about this already as well, that in the history of whether or not adult vaccinations are applicable in the child setting, there's a number of cases. I've listed a couple of here, one for lack of safety and a couple for lack of efficacy. So when we've determined that it's not efficacious in children, we don't expose them to that, not because it's unsafe, but because it won't work. And then thinking ahead, and I think it follows on Dr. Kaplowitz's presentation about what are the consequences if we move forward. Do we need to do additional trials? Do we then add that to the stockpile? And then how would any of the information we gather make our response any different to the one that we would implement if we don't take any action, and trying to value those risks and benefits across the board?
Thank you for that. And finally, for this session, we turn to Professor James Hodge. And Professor Hodge is the Lincoln Professor of Health Law and Ethics at the Sandra Day O'Connor College of Law at Arizona State University, Director of Public Health Law Network, Western Region, one of 5 centers nationally funded by the Robert Wood Johnson Foundation, and Director of the Arizona State University's Public Health Law and Policy Program. His scholarship, teaching, and projects extend into multiple areas of health law, public health law, global health law, ethics, and human rights, with particular expertise in public health emergency legal and ethical preparedness and public health information privacy law and policy. He's a current and former member of several expert committees of the Iowa Institute of Medicine and is a current member of the CDC's Directors Advisory Committee and Policy. Professor Hodge, thank you for being here.
Dr. Wagner, thank you for that very kind introduction. Dr. Gutman, for your invitation to address the members of this commission. It's a real pleasure to be able to join you here this afternoon. Let me tell you what I'd like to try to do in the brief time that I've gotten. That clock is already ticking on me.
That's what clocks do.
Lawyers are so familiar with that, Doctor, I can assure you. So listen, I've got a brief outline of material that I believe some of you may have received. It's called the Ethics of Allocation and Preparedness in Public Health Emergencies. This is a brief 2-page outline. It is dispensing and trying to go through a mountain of material that I'm going to share with you here in these very brief comments. We can go into any depth that you want to in regards to this later. Here's the real essential points that I just want to try to make. Let's talk about, just for so we know, the critical difference between a public health crisis and a public health emergency. These are very different terms legally and ethically. Why? Because when we get to a public health emergency, the legal environment will change. I'll give you a brief snapshot of that. But most importantly, so do the ethics in regards to what and how we may allocate a medical countermeasure, assuming it is even available for our purposes and use. I will distill from a very divergent series of observations across this country at the federal, state, tribal, and local levels, what I call my top 10 core principles for how we are prepared to ethically allocate limited resources in actual public health emergencies. So with that in mind, let's jump right into it. So basically, a public health crisis is something we're all experiencing as we speak. The obesity epidemic is a crisis. HIV/AIDS remains a crisis. Gun control in our urban environments. These are public health crises. Contrast these immediately with public health emergencies, defined and capable of being distinguished by several common elements. First of all, public health emergencies, like the H1N1 pandemic, have a sudden onset. They have a relatively short duration and potentially catastrophic consequences. They have intense impacts on the physical and mental health of this nation or any nation. They have a need for immediate global, national, or regional responses. Public health emergencies will severely potentially have economic consequences. They will change the legal environment instantaneously. And then most importantly, perhaps the most critical definitional capacity of a public health emergency, there will be scarce resources, and our ability to allocate those will be tested significantly. This is exactly what was at the center of the IOM's recent Crisis Standard of Care Committee. When we defined a public health crisis pursuant to setting a standard, it started with, first, we have extremely limited resources. So with that in mind, the legal response to a public health emergency will be significant, it will happen instantaneously, and the environment will change drastically to reflect and respond to those particular issues. So we are prepared through emergency declarations, both in emergency sort of all hazards approaches, as well as in public health emergency declarations that the Secretary of HHS, as she was just here, has the power to issue in several states. We will change the legal environment. We will provide new legal reforms for how we can address these critical concerns, but there's not a thing we can do in regards to those legal changes that will dispense with that critical facet, and that is, how will we make those critical decisions when it's time to allocate those scarce resources? The law provides menu of options, it provides tools we can use, but it does not provide that answer. That's why we need ethics to step in and to help us do that. To be sure, the type of ethics we're going to discuss here, this is not bioethics, in my mind. It's not research ethics. It's not even public health ethics. And while your Executive Director, Lisa Lee, has written very eloquently on the key role of public health ethics, public health emergency ethics is something altogether different as well. So what you're going to see across this country when you look at these critical issues, there is simply no national consensus on what the major important core principles of public health emergency ethics are. You see approaches at every level of government, from CDC to HHS down to local governments, all attempting to provide some ethical guidance on how they will allocate scarce resources. Let me, if I may, distill from that these 10 core principles. These are the ones that I think you're seeing over and over again, and while they can be divergent and at times conflicting, as many principles in ethics are, these are the ones I think you can take to the bank as what and how this nation's trying to work through how we would allocate scarce resources in an emergency. First of all, prevention. Let's talk about this not from the public health prevention perspective in that capacity, but as an ethical principle. Above all else, protect the public's health from preventable causes of morbidity and mortality. The ability to accomplish this, to maintain this, is a core ethics principle driven by that public health emergency recognition. Then there's the principle of soundness, matching responses to what we know works as a best practice in public health. There is no time for guesswork. There is time for using known convention, best practices that really will result in allocating resources in the way possible to further the prevention goal, which is, again, limiting morbidity and mortality. The principle of equity is consistent throughout many of these approaches, providing similar treatment for similarly situated individuals. And you might compare it to an equal protection type of norm from the legal perspective, except here we're talking about a broader base. We're talking about eliminating discrimination based on everything that might be relatable in the human condition. So it's not just about eliminating discrimination on race or ethnicity, but about ability to pay and other factors related to socioeconomic status. These simply aren't legitimate criteria to allocate resources. Don't let them be used from a principle of equity. Tied to that is the principle of what you might see called vulnerability. At times we will dispense essential services and care based on the medical vulnerability of a particular party or group that is most in need of a particular issue. This is exactly what you may have seen violated in regards to the CPRO distribution following 9/11, the anthrax attacks, particularly when we saw CPRO going to certain members of society that had the most possible access when others may have been left on the sidelines, at least in the initial distribution. Transparency. The idea that we're going to make these decisions in some closeted fashion outside of what the public may have an opportunity to provide input, unsustainable according to most people looking at these issues. There's a need for openness in decision making. There is a need for public input, whether that becomes before the event or during the event. Many protocols that you're seeing in place for how to respond ethically build in a transparent factor, something that we can at least have an opportunity for something like due process or input along the way of making these decisions. Reciprocity is a very important principle to mention here because it's one that really builds on the vulnerability facet, but it's really about supporting those who face a disproportionate burden in emergencies because they're on the front lines. They're your healthcare workers, your emergency responders, firemen or other persons involved who have, through their own duty to provide care, given up or put themselves in certain vulnerable positions. How do we respect that? We put them potentially first in line. Say many states, for example, in relation to how we might allocate a particular medical countermeasure. Proportionality. Using the least restrictive alternative where possible. Reserving coercive measures only when necessary. So this particular type of issue in relation to vaccines is really compelling. Would you coercively force individuals to be vaccinated even with a no medical countermeasure that could work for kids? Legally, you could get away with it. I don't think there's any question about that. From an ethics perspective, you have to ask whether that would be ethically sound, especially in regards to historic qualities of some interventions from a public health perspective, going that route and disserving the population. Solidarity, you've talked about and heard about. I like to define it briefly as coordination over competition. We need to share openly. We've got to be able to respond similarly across communities, states, and localities. And this particular norm of an ethics perspective is one that is often looked upon. This fair innings approach is one that you may have heard about. I tend to disfavor it, but let's define it so we have some sense of it. It's about when and where we may prioritize, let's say, for example, the young over the old, or persons with experience, or persons who lack a certain experience over those with experience. This idea that those individuals under the particular circumstance are entitled to some sort of fair inning may drive some allocation decisions. It's particularly rife with controversy because it's so difficult to apply and determine why somebody who lacked a fair innings approach in life would be more or less at risk from all the other bases in regards to that distribution. The final principle I just wanted to suggest for us today in regards to these sort of top 10 core principles of public health emergency ethics and allocation would be accountability. Honestly, let's recognize the decision makers at every level of government and in the private sector that are going to be responsible for these decisions must be accountable for these decisions as well. Some failure to provide an accountability factor in relation to these critical facets may allow for unethical decisions to be made that would never reach back to the actual party involved. These 10 principles are not meant to provide the type of guidance that this commission may find instantly applicable. What I will say is these are the ones that you're seeing over and over again in relation to how government and the private sector are attempting to make these difficult decisions. Developing national consensus on this would be fantastic. But at the moment, that's the snapshot I think that you can take to the bank as accurate for how we're looking through these allocation concerns. Thank you.
Professor Hutch, thank you. Thanks all three of you. We will open the floor, and I believe Amy has a
So I
first
have a
question.
question for Holly. We heard from David DeGrazia earlier, and he presented a different, a framework that would actually not agree with your scales of justice picture. And I wonder whether it's just that you left something out or that you fundamentally disagree. Let me just explain just for a moment. You say if the risks outweigh the benefits, then you don't go forward, and if the benefits outweigh the risk, then you do. But what Dr. DeGrazia suggested, which is part of most frameworks for doing testing, is that there are side constraints, that you don't go forward. So, for example, the benefits of giving out organs from dead people far outweighs the risk to dead people, which are zero, right? And yet we don't just harvest organs. I'm not saying that flippantly, because there's a strong argument on a certain framework that why don't we?
Yeah.
But we don't, and I wonder if you are arguing that not only we should, but we must, because the benefits outweigh the risks.
No, thank you for the opportunity to clarify. I would never advocate that as long as the benefits outweigh the risk, that, you know.
That's why but you ought to be careful with those
Sure,
scales.
well, what I was trying
The
to.
scales are very simple.
Well, what I was trying to
The
articulate
calculations
with
aren't,
this,
but.
absolutely. What I was trying to articulate with the balance was that as we traditionally think about research ethics, we always want to, in our assessment, have at very least risks and benefits in balance. The point I was trying to make, that in our traditional way that we do it, we often look for that balance, and as long as that balance is in sync, we're allowed to go forward. My point here was that when we're talking about intervention where there's clearly no direct benefit, if there is benefit to children, it's benefit to children that is of uncertain measure because there's no immediate risk or harm and/or the threat is uncertain. And so there's no place to put our assessment of the risks of not going forward into the traditional way that we assess risks and benefits.
So let me make the point that I think you've made, but more strikingly, and you made it at one point, but only at one point. You made a very strong point, I think, that we have to consider, which is if you only consider the costs of going forward, you're forgetting about the costs of no action.
Yes.
And the costs of no action are why we're deliberating about this. And we have to take that very seriously. And I think that I just wanted to underline
Yes.
that. At the same time, take very seriously the importance of side constraints.
Right, and so, and I guess I assumed that we were talking in a setting where we were talking about where there'd be an evaluation of whether or not those risks and benefits were in balance or not. That the sort of utilitarian proposal that you made in terms of, you know, harvesting Dr. Kaplitz's organs would benefit many, but we of course wouldn't
wasn't-
sacrifice her.
It was dead people, not live.
Oh,
I
okay,
wasn't
dead
going
people.
there, Holly.
I'd like to get back to countermeasures. Dr. Atkins, Barbara?
Those were all excellent, and the whole morning has fit together extremely well. And I was sitting here thinking, before hearing about the complications of the antibiotics, for instance, for 60 days, and then thinking about the risk of not conducting the trials, I want to push it to the far extreme. When would we decide that we would prophylactically treat everybody in the United States with a vaccine? Because what would we need to have to make that decision? We'd want to know maybe that it didn't have any more complications than a polio vaccine, for instance. We might want to know some other things. But once we had come to that conclusion, then it would, backing it up, be very clear that we would want to right now do dosing studies. We would want to then do efficacy studies, even in children. And then we would want to find out what the complication rate was so that we could make that decision. So it would back us up to the first decision that we were asked to make here if we were ultimately going to make that endpoint decision.
Yeah, and I guess what I was encouraging was to anticipate the consequences in thinking about Are we willing to start the ball rolling?
Yeah.
In this case, and under what circumstances, and how would it then be applied to other MCM settings?
Either the other two
Yeah.
of you want to?
Sometimes I think it's fair to say that you're concerned about when government may have to make a decision to go ahead and vaccinate the population. The population will make that decision for you sometimes. If they see the risk is very real and they're concerned about the potential threat, they'll line up for that vaccination and be banging on government's door to get it. I think
I want
that's-
to know that the vaccine is okay
Sure,
first. and-
exactly. But even they, even reasonable persons will take more risk with a potential unknown vaccine as far as its implications when they see the opposite side of that to be significantly more severe.
And there's the factor of perception of risk as well, because we're actually struggling with the whole issue of pre-event vaccination. And there are certain populations who really would like access to pre-event vaccination, and we're working closely with DHS to set some criteria, at least for a pilot, of how to do this. But again, to expand on what James said, we're also talking about a limited resource. We don't have the resources in terms of anthrax vaccine per se, and that's going to be a challenge for us post-event, as well as with our discussions pre-event, working with first responder populations, for example. But again, with my experience with H1N1 as well, the perception of risks makes a big difference in terms of how acceptable, especially vaccines or any treatment to a population.
Let me follow up on that, because I think the theme, Dr. Kaplowitz, of your presentation was that there is, in your judgment, and correct me if I'm wrong, in your judgment, there is ample motivation to go forward in addition to, or maybe even in spite of, the specific threat level at this point. Is that what I heard?
What I was trying to do was actually a bit of what Holly was trying to do, was to point out risks of not moving forward and putting it in that context. And I really want this to be put in the context of considering everything in a pre-event fashion. My position, and many of us, including Alex, is to look at what we can plan for in advance so that when something happens, we at least have the ability to respond in a reasonable way. It'll never be perfect, because we'll never have perfect plans. But this is an anticipation and factoring in. This is part of what we've been struggling with Dr. Lori's charge to the MBSB.
So I thought if Holly's main point was we have to think about the cost of inaction, which I understand you made other points, but that's an important point that we hadn't really focused on. I thought your important point was that if we, in our deliberations, recommend under certain circumstances going forward with testing safety of a vaccine, we also ought to recommend that it better be available. I mean, that the funding, if we're going to go forward and test this, then it darn well better be available in the context of an emergency, because we've taken the risk part. The government better guarantee the benefit part, to put it dramatically.
Well,
And I thought that's what you may not
Yeah.
want to have said it that strikingly, but I thought you were saying all of the need for having, actually being able to deliver the goods when the time came. And I say that because we have had experiences with our government where the means are available, but they're not delivered.
I think part of what I was trying to get at with the delivery piece is that decisions that are made now are going to impact the ability to deliver. As a better way.
Going a step further.
As a better way to put it, if we have a medical countermeasure that is distributed under different circumstances to children and adults, let's have our message clear, why we have done this, and have we considered the consequences ahead of time? had we thought about that, which really gets to the core of what Dr. Laurie requested of the NBSB. Let's make sure we really have considered ahead of time the implications of decisions being made
That's
now.
the converse of what I was saying. So if we decide not to go ahead with the testing, we should indicate, tell the public why and what the consequences of that would be in the case of an emergency.
Or at least ourselves be aware of the consequences. Now,
Not
but
enough for
you mean
ourselves to
explain-
be aware, right?
I guess I wasn't thinking in terms of explaining to the public ahead of time, at the time, at least. But that's another factor that I hadn't actually gone that far.
Principal,
Yeah, absolutely.
yeah,
And it really
we've got
is
to
an
be accountable
issue.
to the public.
Exactly, Dr. Wagner. It's really an issue where you must recognize developing the measure is great, proving that it could work is great. If you can't get it in the hands of people that really need it under any ethical norms that sustain that allocation decision, you've got an even bigger concern on your hands.
Can I just make sure, Lisa, that I don't think accountability would be satisfied with waiting until an emergency happened to explain to the American public why it wouldn't be. At least we shouldn't be, if we're deliberating ahead of time so we can provide some accountability, whichever way we recommend, and that requires at least informing, if not educating, the American public about what we are and are not prepared for.
Actually, you're right, I agree, and at heart, I wish we were having more of these discussions in a broader sense, because really engaging in that discussion is key to making these important decisions.
Thanks. Perhaps for Dr. Kaplowitz, if there was a decision to go forward, what level of knowledge do you think is needed in order to be able to consider deploying with reasonable confidence an AVA vaccine in children? Obviously, if one looks at immunogenicity and just very common side effects, it's a different scale project than if one is interested in rare side effects, some of which have been the signals that have been seen in children with other vaccines.
Well, for that, I would sit down with Skip Nelson. And seriously, I can't emphasize enough how essential it is that all of us work together on this, from DHS all the way through FDA and CDC, because it's the FDA that is going to be key to making the decision about whether something qualifies for emergency use authorization, for example. Is it enough to have safety data? I have my own understanding, but I would go to them and say, do we need just safety data? What about safety and immunogenicity? What is it that is going to be adequate so that we can then distribute a vaccine or any medical countermeasure under similar conditions to both adults and children? We have an emergency use authorization for use of this vaccine after an event in adults. What would it take in order to be able to do that in children while putting children at minimal risk? And, I've worked with Skip, I've heard him speak numerous times, and we turn to them all the time. So that's the first thing that I would do, because they're going to be the ones making those key decisions.
Skip, your name is being invoked. Do you care to comment on this?
So just very briefly to say what the plan would be in the absence of a pre-event study. So there's two levels of data you need to consider. There's the IND to the EUA transition. In other words, what data do we need to be able to release something under emergency use authorization? And then there's the data you would need to actually label it, which would mean it would be out there for general use. So for adults, anthrax vaccine would be released under an EUA because we have sufficient data based on the pre-exposure prophylaxis experience in the military and so forth to say that it's reasonably, possibly effective and safe. We don't have any data in pediatrics. The current plan would be to release it from the stockpile under what would best be considered a treatment IND, so that the children could get the anthrax vaccine, and the data collection that would occur in association with that IND would be a vaccine adverse event reporting system similar to what was effective in the pandemic. So a similar type of post-vaccine distribution passive reporting system. That would be the treatment IND. That generates some safety data around some of these rare adverse events. Coupled with that would be, in the NBSB report, you would hear that referred to as a non-research IND, treatment IND. Coupled with that would be a research IND, which would be a more intensive IND to get immunogenicity data and active surveillance safety data in a smaller number of children. And I've heard, I'm not with the Center for Biologics, I've heard numbers between 100 and 200, something in that range, that would allow you to have some confidence that you get immunogenicity and then some active surveillance data. That data would allow you then to say that you could administer it under an EUA. Why the difference? You don't need an IRB for an EUA. The informed consent process is different. We could debate how different. Personally, I don't think it's that much different other than getting a signature, because it's now a one-page form for the informed consent. So that's basically how it would be distributed. And when Lisa's talking about how do you explain the difference, currently, if you had a pod, the parent would come in with their child, and the parent would have the EUA with a form that they might look at similar to an influenza form that we all get when we get our yearly, and then the child would have an IND form. Those would look very similar, but the one would need a signature of the parent. So part of the messaging is, why is that different? What do we know? What do we don't know? And I think that's what she's alluding to. So I hope that is helpful to provide some context.
Great clarification. Thank you, Skip. Christine?
Actually, can I start with a question to you, Skip? If the pediatric vaccine was covered under the EUA, wouldn't the parents still need to sign?
There it would be treated much like a treatment decision, and so I guess we all sign our influenza thing, but you wouldn't need an IRB. There'd be some simplification, but it just wouldn't be different.
Okay.
I don't know if we would sign, and we don't need a signature. There's no legal requirement, but I guess we all sign our little influenza form to say that we got it when we get our influenza vaccine. But.
Or maybe you don't.
In this case, I'll put on my, former local public health hat, and what I was referring to is the kind of situation we'd be faced with in dispensing, whether it's antibiotics or vaccine, to a large number of people in a short period of time. And our goal in planning is to limit the chaos that's likely to occur. So that we've had many, many discussions of what it would mean to take that extra time to not only sign the form, but to really have parents understand why they're signing a form for their child versus not for themselves. We have concerns about vaccines in general. It's going to take more time than just handing out packets of pills. And what maybe didn't become clear with all of this is that we really are concerned about anthrax remaining in the environment, hence so much discussion on vaccine. So it's an unknown, but it clearly has the potential to increase confusion and time when you're trying very hard to get measures out as quickly as possible.
So that was going to be the basis of my question. I think the question about what would happen if we don't do this study, I think, is a very important one. But in my mind, that has to be asked study by study. What happens if we don't do it? And I was wondering, and this is why I asked the question about the signature, at a moment of an emergency of that nature, there's going to be chaos no matter what we do. And it sounded to me from what you said, Dr. Kaplowitz, that the two different systems for distribution plus the messaging are both issues that possibly could be dealt with independently of whether or not we do the study. And I guess that's what I was trying to figure out. The messaging could be done way in advance, right? And the question about what's the actual difference on the ground between giving a vaccine to an adult and giving a vaccine to a child, with or without the data, is really the question. And if that could be fixed, then that's not, not something that would drive the decision about doing the study, I guess is what I'm trying to say.
Again, my point was to really consider it as a factor. And believe me, we've put a lot of work into pre-event messaging, especially for those agents that have a material threat determination. So it will be challenging any way you look at it, but it is something that we've had to factor in when doing our planning, especially at the grassroots level with the points of distribution.
Well, it has been a remarkable morning of stimulating testimony. To you three in particular, we thank you for being at this latter session. And to all of our other guests, we hope you'll be part of the roundtable, which convenes.
No, we come back at 1:30.
Oh, we come back at
We have a
1:30.
lunch
I'm
break
sorry, we have
first.
no, and then that's the roundtable, isn't it 1:30?
Yes.
Yeah.
1:30.
So it is 1:30 is, we're both saying the same thing,
Yes.
actually. So anyway, thanks to all of you, and thanks to our guests. We'll see you back here at 1:30.